Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good afternoon. My name is Dr. Ghassan from Iraq, Baghdad, interventional cardiologist. My case presentation is under the title of When Diagnostic Angiogram Became a Nightmare. A lady, 60 years old female, without any risk factors for being ischemic, has history of mild chest pain and dyspnea with an LV ejection fractions of 45%. Underwent diagnostic angiogram to exclude ischemia as a cause of LV dysfunction. The left system was normal. I didn't include the angiogram because of limited number of slides. So with the normal left system, when we start to inject the right coronary artery, as it is clear in the first slide, it looks like the flow in the distal RCA is diminished. And when we took another view, the RA view, we recognize that the opening or the mouth of the JR catheter is not coaxial with the orifice of RCA. It looks like not coaxial. So here it comes in my mind that there is some problem, maybe a dissection. So after that, on the third injection, it becomes clear that there is a spiral dissection. When it starts first as a grade B, then it extends after further injection into grade E or grade F, which is the total occlusion. At that moment, the patient starts to develop severe chest pain, hypotension, and ST elevation. Then at that moment, we changed our strategy. We took a JR guide catheter and we took a whisper guide wire. We were very happy and very lucky in that our wire went into the true lumen. And we make sure by using a balloon 220 just to introduce the balloon to the distal RCA, and then we get it back. Honestly, the IVAS catheter was not available at that time. And the time for the patient was not good for us to do an IVAS. So we start to stent the port of entry. Here, in the iatrogenic dissection, the best management is to prevent the complication. But once it happens, we have to close the door of entry because the door of entry could extend distally to occlude the vessel as well as proximal. And if it extends into the proximal aorta, the complication became more catastrophic. So we started stenting the port of entry with two stents. The first one is a 3.534 and the second is a 3 by 33 millim. And it is clear that the flow in the distal RCA becomes clear and better, but still there is hematoma at the mid-segment. And after covering that segment, we noticed some remnant of dissection at the mid-segment, which is also covered by another stent. And if we look by this spider view, that at the area of ostium of right coronary artery, it looks like there is a dissection flap. And I was not comfortable to leave that segment without covering because it may extend to ascending aorta. So I stent it with a 3.5 by 9 millim stent and flaring the stent properly. And these are the final result. I think this is the ECG. The first one is before the procedure, and the second one is after the procedure. It looks normal without any residual changes. I think my presentation comes a little bit parallel with the presentation of my colleague, Dr. Aram, is that we can face complication with the diagnostic procedures. Most of these procedures comes from either the guide catheter, either direct injury, or injection of vigorous contrast while the catheter is deeply engaged into the coronary artery, or progressive manipulation and excessive manipulation of catheter, as well as the hard guide wire or the or inflation of balloon. Here we are diagnostic procedure, so most likely the complication comes from either non-coaxial catheter with the origin of the coronary artery or vigorous injection. The most important message is that if you recognize dissection, do not inject further because this will expand the dissection. So complication can happen at any time and can be minimized by increasing the learning curve, especially in radial curve. Here, the radial is different from femoral is that we need more complex manipulation, the catheter as well as the diagnostic guide wire. Early identification and awareness of complication can help to manage complication. IVUS is necessary and very useful. It helps us to identify the port of entry, the length of dissection, the size of the vessel to stent, and whether there is a ostial progression or not. And the prevention of aortic extension is crucial. And thanks.
Excellent. Thank you very much. Again, that's